Welcome to the ROHDEO webinar entitled The Burden of Tobacco, Tobacco Control, and Advocacy, Policy Strategies for Oral Health. I am Annalise Cothran, ROHDEO Coordinator. Thank you for joining us today. I thought we would start by giving a little background for those of you who may not be familiar with ROHDEO. The repository of oral health data for evaluation and outcomes is a statewide database of basic screening survey oral health indicators, access to care information, and demographic data. Programs across Texas contribute data annually. Each year, data are synthesized and published on the ROHDEO website for public access. ROHDEO is a partnership between UT Health San Antonio School of Dentistry and the Texas Department of State Health Services Oral Health Surveillance Program, supported by funding from the Health Resources and Services Administration. This webinar series aims to bring dental public health information and initiatives to both ROHDEO users and contributors, as well as national partners who are interested in learning more about the oral health of Texans. You can learn more about ROHDEO by visiting the website www.rohdeo.org. This webinar is the 6th in our series. Previous webinar topics include collaboration on health IT, public health messaging in a digital era, older adult oral health programs, access to care data presented by the ADA Health Policy Institute, and using data to influence oral health policy. As mentioned, this webinar is being recorded and will be made available for review later on the ROHDEO website. You can review any of our previous webinars on the ROHDEO website under the Webinars tab or on our ROHDEO YouTube channel. We're also on Facebook and Twitter. Follow us on social media to give us your feedback on the webinar and tell us what you'd like to see in future webinars. We are excited to keep the conversation going. Lastly, I would like to mention that ROHDEO has redesigned our website and visualizations. If you visit the State and County Health Data tab, you'll see that we have 2 pages of visualizations available with more planned stories on the way. Feel free to visit and give us feedback. Before we start, I wanted to review a few housekeeping details. This webinar will last approximately 45 minutes, after which Dr. McMillan will answer questions. If you have a question, please type it in the question box throughout the webinar. If typing in the chat or question feature, please make sure that you are typing to the entire audience or sending to all. At the conclusion, the presenter will read and answer questions. If he does not have time to answer your question, or if you have a follow-up question, we will provide Dr. McMillan's slides and contact information on the ROHDEO website. Or you can email us at rohdeo@uthcsa.edu and we will connect you with the speaker. This webinar will briefly summarize the acute and chronic conditions caused by tobacco and nicotine use, as well as the population health and economic burden tobacco places on the U.S. To address this burden, the impact of tobacco control strategies, including tobacco price increases, smoke-free policies, cessation access, Tobacco 21, and media campaigns will be discussed. Dr. McMillan will conclude with strategies for implementing these interventions. Dr. McMillan is a professor with a joint appointment with the Social Science Research Center and the Department of Psychology at Mississippi State University. He also serves as investigator within the American Academy of Pediatrics Julius B. Richmond Center. Dr. McMillan serves as principal investigator for the Surveillance and Evaluation Services Grant for the Mississippi State Department of Health's Office of Tobacco Control. His research has been published in Pediatrics, the New England Journal of Medicine, the American Journal of Public Health, JAMA International Medicine, Nicotine and Tobacco Research, the Journal of Rural Health, and the Journal of the Mississippi State Medical Association. Please join us in welcoming Dr. Robert McMillan.
Good afternoon. I would like to start by thanking ROHDEO and Annalise Sims-Cothran for inviting me to lead this webinar, and to each of you for participating in this session. Today I'm going to discuss the health and economic burden of tobacco, several strategies for reducing this burden, and then advocacy for these strategies. As many of you know, tobacco is the leading cause of death in the United States, and both combustible and smokeless tobacco impact oral health as well as overall health. Tobacco control, in many ways, is one of the great public health success stories of the past half-century. America began the 20th century with very low rates of cigarette smoking, yet by the mid-1960s, almost half of adults were current cigarette smokers. The Surgeon General Report of 1964, documenting the research on the harms of cigarette smoking, helped to launch a successful public health movement. According to the most recent data from the 2017 National Health Interview Survey, only about 14% of adults are current cigarette smokers, compared to 42% in 1965. Through more than 50 years of tobacco control policy, research, and evaluation, we really do have a good idea about what strategies reduce initiation, promote cessation, and protect non-smokers. Although we have tended to focus a lot of our prevention efforts mostly on combustible cigarettes, there was a time in our history when cigars and chewing tobacco were the most commonly used forms of tobacco. At the end of the 19th century, chewing tobacco, represented by the dotted background in this chart, was the most popular form of tobacco use. Interestingly, public health and policy efforts at the beginning of the 20th century focused on preventing infectious disease spread by spitting tobacco juice rather than on the chronic diseases and oral health that we tend to think about today. Product preferences began to change in the early 1900s. The invention of an automated cigarette rolling machine made it possible for tobacco companies to inexpensively and quickly produce a lot of cigarettes at the end of the 19th century, and their popularity escalated through the first half of the 20th century. As you can see from this chart, cigarette use gained in popularity through the mid-1960s, while consumption of other tobacco products began to decrease. After the release of the first Surgeon General report in 1964, consumption of each of these products had been on the decline for more than 50 years. Although tobacco control is one of the great public health successes of the past 100 years, tobacco remains the leading cause of death in the United States. There are currently a wide variety of tobacco products available in the U.S. market. Cigarettes are the product we typically put the most resources towards prevention, given that they cause the most morbidity and mortality and have the greatest economic and health burden. Cigars are actually a wide range of products, including premium cigars such as the one pictured, but also a lot of small flavored cigars, some with filters, some without. And smokeless tobacco is obviously a risk factor for poor oral health. Hookah, which are a lot more dangerous than a lot of adolescents and young adults realize, are gaining in popularity. And e-cigarettes, relatively new to the market, really also very widely in terms of product design, quality control, and the ability to deliver nicotine. It's important to note that none of these are safe forms of nicotine delivery systems, but some are probably more harmful than others. Today, I'll focus on the burden of combustible and spit tobacco products and briefly touch on the emerging evidence on e-cigarettes. Focusing first on smokeless tobacco and the burden it places, the health burdens of smokeless tobacco include several forms of cancer, damage to oral health, and reproductive health. Smokeless tobacco use increases the risk for cancer. Smokeless tobacco products contain cancer-causing chemicals, and the amount of these chemicals varies by product. The higher the level of these chemicals, the greater the risk for cancer. Smokeless tobacco has been linked to cancers of the mouth, the esophagus, and even the pancreas. And it's important to note that pancreatic cancer has a very low 5-year survivability rate. So anything that we could do to decrease the prevalence of a risk factor for this disease would be a huge benefit to health. Smokeless tobacco also causes oral diseases. It can cause white or grape patches inside the mouth that can lead to cancer, and it also is an important risk factor for gum disease, tooth decay, and even tooth loss. There are also reproductive and developmental risks from smokeless tobacco use. Use during pregnancy can increase the risk for early delivery and stillbirth. Also, nicotine and smokeless tobacco products that are used during pregnancy can affect how a baby's brain develops before birth. As mentioned earlier, cigarettes create an enormous health and economic burden. The sheer quantity of harmful chemicals and compounds in cigarette smoke leads to this extreme burden. As one of my colleagues in tobacco control notes, smoking cigarettes is like inhaling a whole chemistry lab. There are over 7,000 chemicals and 70 carcinogens in cigarette smoke. Tobacco use is the leading cause of death in the United States, accounting for more than 20% of all deaths in the United States. Most of these deaths, as I mentioned earlier, are due to cigarette smoking. Smoking kills more people than alcohol, AIDS, car accidents, illegal drugs, murders, and suicides combined. 480,000 is a big number, but it may be somewhat difficult to conceptualize the impact of 480,000 deaths each year. In public health, quite often we use images of airplane crashes to illustrate the impact of some preventable risk factor. 480,000 deceased Americans each year is the equivalent of 3 747s crashing each day. Obviously, if this happened in just one day, there'd be a huge public outcry for action. However, I think that there's a problem with this analogy of using 747s. Although it illustrates the tragedy of 480,000 lives ended prematurely, it glosses over the enormous amount of prolonged suffering and profound economic burden of these deaths. Airplane crashes typically result in fairly quick deaths and relatively inexpensive medical costs. A more appropriate analogy might be for 3 747s sliding off the runway each day and causing long-term pain and disability, eventually mortality, and astronomical healthcare cost. Cigarette smoking has a very long list of ways in which it can harm health and lead to death. Basically, tobacco smoke harms most parts of the body. It enters through the pulmonary system, immediately goes through the cardiovascular system, and as the cardiovascular system can deliver those tobacco chemicals and compounds to every cell in the body. This graphic is from the most recent Surgeon General report. All of these diseases can be caused by smoking. The diseases in reds are ones in which the causal link has been established between the most recent and the previous Surgeon General's report. So there's still diseases that we're discovering links to tobacco use and cigarette smoking with. Cigarette smoking also presents health risk for specific populations. Women of reproductive age are at risk for infertility, conception delay, pregnancy complications, menstrual irregularity, and earlier menopause. And pregnant women who smoke are at risk for poor prenatal and neonatal outcomes. These risks include miscarriage, cancers, fetal death, preterm deliveries, low birth weight babies, ectopic pregnancies, sudden infant death syndrome, placenta previa and placental absorption, as well as various birth defects. Cigarette smoking is not just harmful to smokers and fetuses. Secondhand smoke also places a large health and economic burden on non-smokers. These harms are particularly unfair to people who have no voice and no choice regarding their exposure to tobacco smoke. These vulnerable populations include children who live in homes where people smoke inside, employees who work in restaurants and casinos where smoking is permitted, people who live in multi-unit housing and whose neighbors smoke indoors, and anyone else who's involuntarily exposed to tobacco smoke. Most of us are probably familiar with many of the long-term health consequences of secondhand smoke exposure, such as cancer and heart disease. But children who are exposed are also at risk for learning and behavioral problems. In addition to the long-term chronic conditions caused by secondhand smoke exposure, there are immediate short-term consequences for exposed children. These include respiratory tract infections such as pneumonia and bronchitis, deceased pulmonary function, tooth decay, and house fires. There are also important risks for adults. Numerous studies from across the globe have found that heart attack admissions to hospitals have declined after governments implemented smoke-free policies. Basically, cardiologists started to anecdotally notice they were having fewer clients after Pueblo, Colorado and Helena, Montana went smoke-free. And then actually quasi-experimental studies looking at objective data from hospital admissions showed that admissions for heart attacks had actually decreased after these communities went smoke-free compared to control communities. In 2010, the Institute of Medicine reviewed all the quasi-experimental studies looking at pre- and post-smoking ban heart attack admissions and concluded that secondhand smoke exposure does indeed increase the risk of heart attacks and that smoking bans reduce heart attacks. And obviously this is not necessarily among healthy young adults, but among people who have cardiovascular disease and are at risk for heart attacks, secondhand smoke acts like an anti-aspirin. The person I just described might take a baby aspirin every day in order to reduce their blood platelet activity, to reduce the likelihood of a blood clot. Well, cigarette smoke does the opposite and increases platelet activity, increases the risk of a clot, which could turn into a brain attack or a stroke or a heart attack in vulnerable populations. Moving on to another type of tobacco product. Over the past decade, a new type of nicotine product has gained popularity among youth and adults. I'd like to briefly summarize what the science tells us about the health risk of these e-cigarettes. There's been a lot of discussion and debate about the possible public health impact of these products. And last January, the National Academy of Sciences, Engineering, and Medicine brought together a group of experts who reviewed all of these studies looking at these products, and they released a consensus report, or you could call it a comprehensive review of the scientific literature on the public health consequences of these products. Among their many conclusions, I'll focus on some of the actual individual health issues related to e-cigarettes. The authors concluded that there was substantial evidence from good quality observational studies and or controlled trial studies that demonstrated that exposure to potentially toxic substances from e-cigarettes is significantly lower compared with combustible cigarettes. That's not to say that these products are safe. It's just to say that they're likely less dangerous than cigarettes, given that they often have lower levels of these toxic substances found in cigarettes. But they also found that e-cigarette aerosols can affect the cardiovascular system and damage DNA. However, the long-term consequences of these effects on cancer and heart disease are uncertain, given that we haven't had time yet for these long-term problems to develop. There were also some conclusions regarding injury risk for e-cigarettes. The report concluded that e-cigarettes can produce injuries or poisonings. E-cigarettes, particularly ones that have been modified by the users, can explode. A lot of this has to do with the quality of the lithium battery and charging. Clearly, an exploding e-cigarette in the mouth is not good for oral health. And in preparing for this presentation, using Google, I found several graphic images of people whose mouth had been severely injured with explosions, but I felt like perhaps they were a little bit too graphic to include in this presentation, but if you're curious, they're available online. These e-liquids can also pose a poison hazard, especially for young children, given that many of them, as we'll see in a few minutes, come in flavors that are attractive to children. Having discussed the health burdens of tobacco and nicotine products, I'd like to move on to their economic burden. In addition to the profound health burden created by tobacco, there's a substantial economic burden. In the United States, we spend at least $170 billion each year for medical care of adults with diseases caused by secondhand smoke. $6 billion of this is due to diseases caused by exposure to secondhand smoke. Tobacco use also costs the United States over $150 billion each year in lost productivity. Although the short and long-term health and economic burden of tobacco is profound, there is some good news. We have almost 6 decades of research examining effective strategies for reducing tobacco use and protecting non-smokers from tobacco smoke. This infographic from the Campaign for Tobacco-Free Kids provides a useful summary of many of these strategies, and I'll discuss many of these today. These include raising the age of tobacco sale to 21, increasing the cost of tobacco products, hard-hitting media campaigns, prevention programs, passing smoke-free laws, and banning flavored tobacco products. One important aspect of tobacco use to recognize is it is heavily influenced by social and environmental factors. When we think about the harms of tobacco, we tend to think about the non-communicable diseases that it causes. It is also useful to think of it as an infectious disease. You get it from the tobacco companies. Historically, our media and society have been flush with pro-tobacco marketing and social norms. And even today, annual tobacco industry spending on marketing its products nationwide is almost $9 billion or $24 million each day in the United States. To counteract these pro-tobacco social forces, strategies are needed that change the social climate of tobacco by denormalizing and complicating tobacco use. By complicating, I mean making it more difficult for smokers and other tobacco users to use their product and to, if they're underage, to obtain the product. These are some of the strategies that I will discuss today. I want to point out, though, that state governments have the authority to pass, implement, and enforce these types of laws concerning the sale and price of tobacco products, including those based on pack size. In most jurisdictions, local governments also possess this power. However, some states preempt local governments from enacting certain tobacco control laws that are more stringent than state law. So every state can implement some of the policies that I'm talking about today, but also many states at the local level, these policies can be implemented. And one of the things that we'll see towards the end of this talk is that quite often it's a lot easier to implement local policies before state policies because the resistance usually is to these policies is weaker at the local level than at the state or national level. Beginning with financial disincentives for tobacco use, that was one of the first strategies I want to talk about. The price of cigarettes is significantly related to their consumption. When cigarette prices go up, people tend to smoke less or even quit. As you can see from this chart, the price of cigarettes began to increase in the 1980s and increased sharply starting at the end of the century towards the late 1990s. And you can see that declines in cigarette sales demonstrated an opposing trend. Consumption began to go down as prices went up. So even though nicotine is highly addictive, there is a price elasticity. If the price of the product goes up, demand goes down. There are several strategies for raising the price of a pack of cigarettes or any other tobacco product for that matter. Regulating the sale or the price of tobacco products based on minimum packaging requirements is one way to reduce tobacco use by raising prices. A single cigarette, cigar, or pouch can be sold at a fraction of the price of a pack. This makes the product more accessible to all users, but especially appealing to youth who might be experimenting with different tobacco products and are extremely price sensitive. Another approach to raising the price of cigarettes or any tobacco product is minimum pricing laws. These laws typically require a minimum percentage markup to be added to the wholesale and or retail price in order to increase the cost to the consumer. Currently, half of U.S. jurisdictions, 25 states, and the District of Columbia have minimum price laws for cigarettes. Again, it's one strategy for artificially raising the cost of these tobacco products to reduce demand. Taxes are probably the most common approach to increasing consumers' costs for tobacco products. The current federal tax on a pack of cigarettes is $1.01. There's a lot of variability, but the average state cigarette tax is $1.72. This map shows the state cigarette tax for each state. Despite the fact that many states have a low state cigarette tax, survey after survey demonstrates strong support for higher taxes among both Republicans and Democrats. This is not a partisan issue. Tobacco taxes really do have three strengths. By reducing tobacco consumption, they are a public health win. if fewer people smoke and those who continue to smoke smoke less, that's going to be good for public health and reduce the health and economic burden of tobacco. By increasing tax revenue, they are a budget win. Even those states sell fewer cigarettes when they raise the price of the cigarette tax because of that reduced demand, they'll generate a lot more money for each pack of cigarettes, so their overall revenue goes up. And finally, because both Republican and Democrat voters support these taxes, it really can be a political win for entities that pass these taxes. Smoke-free laws and policies are another important strategy for tobacco control. Initially, these policies were intended to protect non-smokers from tobacco use. However, these policies also serve to denormalize and complicate tobacco use so that fewer youth began to smoke and more adult smokers began to try to quit, and if they couldn't quit, they began smoking less. Basically, as adults were told they could not smoke in restaurants, could not smoke in their work site, they got the message that they were not engaging in a normative behavior, but also the complicated factor of taking a smoke break in a high-rise working environment gets in the way of interrupts the tobacco use behavior as well. This map illustrates states, cities, and counties that have smoke-free laws. As we saw with the state cigarette taxes, there's a large amount of geographic variability in the implementation of statewide smoke-free laws. They tend to be, I'm sorry, sorry about that. There's the map. Okay, sorry about that. As you can see from this map, there is a lot of geographic variability. They tend to be more common in northeastern states, in western states, in midwestern states. Although the Southeast has not been very good at passing statewide smoke-free laws, as you can see in Texas, South Carolina, and Mississippi, and that several states have had a lot of success in passing local ordinances. Smoke-free policies for multi-unit housing, apartments, and condominiums are also becoming common. The U.S. Department of Housing and Urban Development has implemented a rule requiring all 3,100 public housing authorities across the United States to have a smoke-free indoor policy for all indoor places, including private units, in place by July 30 of this year. That will end up protecting a whole lot of at-risk vulnerable populations in the United States. Also, many apartment and condominium complexes are voluntarily implementing smoke-free policies, and many communities or localities have implemented tobacco policy disclosure laws requiring leases to disclose the tobacco policy to residents. So when someone signs a lease, they do so knowing whether or not they are at risk of being exposed to tobacco smoke by their neighbors. There are also several other places which are smoke or tobacco free, either due to law or policy. Several states have passed laws requiring or prohibiting the use of combustible tobacco products in a car if a child is present. Many hotels and rental car companies prohibit the use of combustible tobacco products and e-cigarettes on their property. Many communities have passed tobacco-free and smoke-free beaches. Part of that is to protect the quality of the air. A lot of that also has to do with frustration over the litter from cigarette butts and cigar butts. Many universities and hospitals have also implemented policies where their entire campus, both indoors and outdoors, are tobacco-free. Another exciting strategy, and fairly recent, to reduce youth tobacco use is to raise the age of sale for tobacco products to 21. That is, vendors cannot sell tobacco products to anyone who cannot prove that they are at least 21 years of age. This policy addresses teen tobacco use by making it harder for minors to get tobacco products. It's effective because it puts legal purchasers outside high school students' social networks. Basically, lots of high school students know 18-year-olds. Much of the senior class in a high school is 18. But it's much less common for a high school student to have a 21-year-old friend who's able and willing to go buy them tobacco products. To date, 5 states and approximately 300 localities have increased the age of sale to 21. These states include California, New Jersey, Oregon, Hawaii, and Maine. And it turns out that these types of policies are pretty popular among U.S. adults. In a study that we published in the journal Tobacco Control, we found strong public support for raising the age of sales. Almost 3/4 of U.S. adults supported raising the age of sale to 21, and even more than half of smokers did so. Interestingly, we found that more than 60% of 18 to 20-year-olds, the group that would be directly affected by this policy, support this type of policy. And the empirical evidence suggests that this policy can be effective. This is a study published by Jonathan Winikoff and his colleagues in Massachusetts. They looked at Needham, Massachusetts, which is a suburb of Boston, and one of the very first, if not the first, municipalities to pass a Tobacco 21 ordinance. And results from regional use surveys suggest that raising the minimum age sale to 21 for tobacco contributed to a greater decline in youth smoking relative to communities that did not pass this ordinance. Although youth smoking declined in both Needham and the other regional localities, the rate of decline for Needham was statistically significantly greater. So this is the first study really to look to see if what happens to adolescent smoking rates if we raise the age to 21. And this study suggests that you will actually see a pronounced decrease in tobacco use or cigarette smoking. Another strategy mentioned about tobacco-free kids is hard-hitting media campaigns. And there's several out there that are really well thought out, pilot tested, cognitively tested, are subjected to rigorous evaluation after they've been implemented to look at their impact. And three that I'd like to talk about today come from, one's from the Centers for Disease Control, one is from the Food and Drug Administration, and the other one is from a nonprofit organization called the Truth Initiative. The Centers for Disease Control developed the first campaign that I want to cover. The Tips from a Former Smoker was implemented in 2012 and has had various media plays over the time since then. The goals of this campaign were to build public awareness of the immediate health damage caused by smoking and exposure to secondhand smoke, encourage smokers to quit, and very importantly, make free help available to them, and encourage smokers not to smoke around others, and encourage non-smokers to protect themselves and their family from exposure to secondhand smoke. And I'd like to briefly show you a 30-second clip from one of these.
When you have a hole in your neck, don't face the shower head. Keep your stomach covered when you're outside. Be very careful shaving. Get used to eating only soft foods. Clean out your speech valve twice a day.
You can quit. For free help, visit cdc.gov/tips.
As you can see, this campaign is meant to alarm smokers, and it has a certain cringe factor to it.
You asked me, are you a writer, Judy?
Okay, sorry, I gotta fix this. Sorry. Sorry, YouTube launched itself. I was afraid that might happen. Let me go back to the presentation. Okay. As you can see, the campaign is meant to alarm smokers, but it also attempts to increase self-efficacy for cessation by providing information about how to contact a free quit line. Evaluation research indicates that the campaign has had a positive impact. Since the Tips from a Former Smokers campaign began in 2012, the CDC estimates that more than 5 million smokers have attempted to quit because of the campaign, and conservatively estimates that more than 500,000 of these people have actually quit for good. So no campaign is going to be perfect, but 500,000 people who are able to successfully quit smoking, is a very, good public health outcome. Another campaign that I want to cover targets youth smoking. The FDA's campaign, The Real Cost, seeks to educate at-risk teens about the harmful effects of tobacco use. Their goal is to prevent youth who are open to tobacco from trying it and to reduce the number of youth who move from experimenting with tobacco to regular use. This campaign launched nationally in 2014 across multiple media platforms, including television, radio, print, web, social media, and out-of-home sites like billboards. Here, in addition to the still photo that I've got on the screen, I want to show you one of their 30-second clips as well.
Pack of cigarettes, please. It's not enough. What's a pack of smokes cost? Your teeth. Smoking can cause serious gum disease that makes you more likely to lose them. See you again. What are cigarettes costing you?
Results from the first study to evaluate the impact of this campaign indicate that exposure to the real cost from 2014 to 2016 was associated with a 30% decrease in the risk for smoking initiation, preventing an estimated 350,000 United States youth from the ages of 11 to 18 from smoking. This campaign has also recently launched a campaign against spit tobacco as well. The final campaign that I want to discuss also addresses youth tobacco use. The Truth Initiative is America's largest nonprofit public health organization dedicated to tobacco prevention. Their goal is to make tobacco use a thing of the past. The image on this slide demonstrates one of their messaging themes by exposing the facts about marketing tactics for tobacco and of the industry behind these tactics. They have other messages as well, and I want to show you again one 30-second ad from this campaign. Okay, those were three of the probably the three national campaigns that are the most hard-hitting and have had the most impact in the United States. Again, two of them are really focusing on youth, and the tips from a former smoker is focused on adults. Going back to adults, I'd like to talk about another strategy, which is access to cessation services. Providing cessation services to tobacco users is also an important strategy for reducing the burden of tobacco. Brief counseling is one inexpensive and can be a very effective approach. We need to address tobacco use whenever an individual comes in contact with the healthcare system. And it doesn't have to be doctors asking, just doctors asking. It can be dentists, nurses, social workers, or even a physician's assistant. By broadening the number of providers who consider this issue part of their responsibility to treat, more smokers will get the support they need to make a successful quit attempt. Several years ago, my colleagues and I examined whether very brief counseling increased quit attempts. We were interested in whether or not there was a dose effect for brief counseling in making a quit attempt. That is, would smokers be more likely to make a quit attempt if they received brief counseling from more of their contacts with healthcare providers? We asked parents who smoke cigarettes if they had been advised to quit smoking in the past year in 3 healthcare locations. We asked, did your dentist advise you to quit? Did your primary care provider advise you to quit? And did your child's doctor advise you to quit? We found a dose effect. The more places that a person was advised to quit, the more likely that parent was to have made a quit attempt of at least 24 hours. You can see that especially if all 3 healthcare providers that we asked about advised a person to quit, that really increased the likelihood that they would make a quit attempt. And even if they weren't successful, we know that quite often it takes many people many attempts to quit, and so each attempt might be the one that's successful. Individual, group, or telephone counseling, such as the Quit Line, are also effective ways to help people to quit smoking. There are behavioral therapies, such as training and problem solving, that can be effective. And for people who've tried several times unsuccessfully to quit, treatments with more person-to-person contact and more intensity, such as more or longer counseling sessions, can be effective. There are also medications to help people quit. There are nicotine replacement products, and there are prescription non-nicotine medications such as bupropion and varenicline. These block the effects of nicotine on the brain and help with cravings and withdrawal symptoms. Counseling and medication are both effective for treating tobacco dependence, and using them together is more effective than using either one alone. Another strategy to denormalize and complicate tobacco use is the tobacco-free pharmacy movement. As early as 1971, the American Pharmacists Association adopted the position that pharmacies should not sell tobacco products because they are antithetical to their role as healthcare providers. There's a fundamental conflict between pharmacies' role in promoting health and the sale of tobacco products that kill nearly 500,000 Americans each year. Currently, there are more than 56,000 pharmacies in the U.S., 2/3 of which are now owned by chains of discount stores, supermarkets, and drugstores. In stark contrast to locally owned independent community pharmacies, which stopped selling cigarettes and other tobacco products decades ago, virtually all of the chain stores still display cigarettes at the checkout counter. However, CVS and Target have ceased tobacco sales. By not selling tobacco products, retailers and pharmacists can reduce the availability of tobacco products and send the message to kids about the dangers of tobacco smoke, and also support tobacco users in their efforts to quit. We know that there are several things that trigger relapse among smokers who are trying to quit, and it's ironic that if somebody's shopping for medications at the pharmacy to treat a disease caused by their tobacco smoke, they're tempted by tobacco products when they're checking out. Fortunately, there's a lot of support in the United States for this type of movement. A recent Center for Disease Control study published in the American Journal of Preventive Medicine found that 2/3 of U.S. adults, including nearly half of current cigarette smokers, support prohibiting tobacco sales in pharmacies. So this is an idea that's not out of left field. There's still a couple more strategies that I'd like to address briefly. The Tobacco Control Act of 2009 banned the sale, distribution, and manufacture of cigarettes that contain flavors other than tobacco or menthol. The act did so because flavors mask the harsh taste of tobacco, making it easier for kids to get hooked on nicotine. Currently, no flavors are banned from other tobacco products, including cigars and e-cigarettes. However, the FDA is examining currently options for regulating other flavored tobacco products, and also such as cigars and e-cigarettes, but also perhaps prohibiting menthol from cigarettes. The images on this slide are from a campaign by the California Department of Public Health effort to educate people on the impact of the flavored products on kids. This is very recent. It was released a couple of days ago. This is a couple of print ads or captured from their website. The one on the left is demonstrating that, you know, a lot of these products are being packaged in ways that are kind of cute and clever, but they certainly might be appealing to youth, such as the fake juice box. It is actually an e-cigarette juice box. And then the response from Tobacco Free California was the tobacco industry now has a kids menu. The last clip I want to show you is from their campaign.
Today I'm reviewing Pebbles Donuts. Let's get into it. Guys, that is some good stuff right there. It's like donuts and cereal, no burn or anything. This is so good. High nic, I heard, you know, a lot of nicotine in here.
Although the FDA has not yet acted on flavors in e-cigarettes or cigars for that matter, local action is possible. To my knowledge, no state has done anything at the state level to address flavors in tobacco products, but several municipalities have done things to restrict flavors. Providence, Rhode Island, Boston, and New York City, and Chicago have all taken efforts to restrict flavors in tobacco products. So it is possible at the local level to try to address this while we wait for the FDA to do it at the national level. The last policy that I want to address concerns packaging and warning labels. The image on the left is the one currently used as a warning label for cigarettes. You'll note that it's fairly bland, it's text-based, it's in only one color. The Tobacco Control Act requires the FDA to include new warning labels with color graphics depicting the negative health consequences of smoking on cigarette packages and in e-cigarette advertisements. The new warning labels were supposed to be graphic and cover the top half of the front and back of a pack of cigarettes. The image on the right is a mock-up of the proposed warning labels. As you can see, they're much more visually impactful, and they take up a lot more real estate on the pack of cigarettes. In 2011, the FDA published a rule requiring these warnings. However, the tobacco industry challenged these warnings on the basis of the First Amendment and freedom of speech. And in 2012, the U.S. Court of Appeals vacated the rule that the FDA had passed. And in 2013, the government decided not to seek further review of the court's ruling. So to date, the FDA is taking no action on implementing these graphic warnings that are required by the 2009 law. However, the FDA is actually being sued right now over its delay in issuing a final rule. The legal action was launched by 8 public health and medical groups, including the American Cancer Society and the American Academy of Pediatrics, and several actually individual pediatricians. So stay tuned. I've spent the last several minutes discussing strategies to prevent youth initiation of tobacco use, to promote cessation, and to protect non-smokers from tobacco smoke. Next, I'd like to briefly discuss strategies for implementing these policies and laws. The first strategy involves local and statewide coalitions that can educate people and policymakers about the burden of tobacco and the benefits of these policies. One of the first steps is to get lots of people in a community or a state aware of the dangers and harms of tobacco and supportive of policies that can reduce this burden. These coalitions can also be very vocal advocates for policy, and they can speak in a very unified voice that does indeed influence policymakers. In my own experience in working with Mississippi and at the local and state level, one of the most important things that can happen for policy change with elected officials is their phone to ring and getting unique messages. And coalitions can be very helpful in doing that, rather than a politician or elected official simply receiving 50 form emails that somebody clicked on to send. Hearing their phone ring and hearing a unique message from a constituent, particularly one they have a connection to, can be important. Another important way to implement these policies is to having a policymaker or a business leader or some other community leader who is willing to champion a policy, and this can be very effective. I was recently just loosely involved in the New Orleans effort to implement a smoke-free ordinance, and remember, they've got bars, they've got a casino, and there was a lot of resistance, but the current mayor, she was a city council member at the time, and many local well-known musicians were the champions. And because the woman who became mayor, and obviously local musicians in New Orleans have a lot of respect, they were able to get a lot of action on that smoke-free ordinance. So having a champion can be really important. And finally, healthcare providers are in a unique position to reduce the burden of tobacco and push for policies that can reduce tobacco use. In the clinic, through brief counseling, you can influence youth tobacco use, promote adult cessation, and even affect household smoking rules. But in support of tobacco control policies, healthcare providers have a very strong voice. In addition to your influence due to expertise in matters of health, you also have social relationship with people in the community who make decisions. You've taken care of their teeth and probably the teeth of their children. They look up to you. In closing, I want to talk about just briefly, we've had a lot of success in reducing the cigarette smoking in the United States. The adult smoking prevalence has been on the decline since 1965. And after a short period of increased prevalence of youth smoking during the 1990s, some of you may remember Marlboro Miles and Camelbacks, which were great lures for teens in the early 90s. Youth smoking has been on the decline since the mid-90s as well. On the horizon, though, there is some concern about e-cigarette use. E-cigarettes are becoming increasingly common and popular. and the use is on the increase in American youth. And several longitudinal studies demonstrate that e-cigarette use among non-smokers at baseline is a risk factor for future combustible cigarette smoking. So in sum, although we have successfully implemented many policies to reduce the burden of tobacco, there is a wide geographic variability in the implementation of many of these policies, and many Americans, particularly those in places that do not have a statewide smoke-free law and have a very low state cigarette tax, are really vulnerable and at increased risk for using tobacco products. Thank you very much, and I will open the floor to questions. There's our website, MississippiTobaccoData.org or mstobacco.org.
Thank you so much, Dr. McMillan. That was a wonderful presentation. I just want to remind people, if you do have questions, that you can type those into the question box and I will read them for Dr. McMillan to answer. The first question that I have here is, tobacco programs largely target low-income persons, and there are strategies for racial and ethnic minorities. What community-based cessation policies are focused specifically for these communities?
Okay, so make sure I understand that question correctly. Focusing on at-risk vulnerable populations due to low income or low socioeconomic status, what are the cessation resources available?
Right, maybe what are the policies that help specifically with these communities? What strategies have been successful?
Okay, the two strategies at the macro level that can be very effective, smoke-free policies go a long way towards motivating people to make a quit attempt, just because of the inconvenience factor as well as the denormalization of the product. So I'm hoping that the HUD rule, House and Urban Development, that all public housing has to be smoke-free by the end of July of this year will help to promote cessation. And another thing is that people are very price sensitive. One of the things you hear about with tobacco taxes is that it's a regressive tax because it hits disproportionately people of low income. That's the group that's most likely to smoke. So by increasing the price, continuing smokers will indeed have to pay a higher disproportionate price for their tobacco products, but also it will help to motivate a lot of low income smokers to actually quit smoking. The challenge here is, this is my own personal belief, is that if you're going to raise the price of cigarettes through taxes, and it's just going to disproportionately affect low-income people, you really need to put a lot of that new income back into resources such as the quit line and free medications to help people to quit smoking. I don't think it's fair to take something that's addictive, raise the price, and then tell people, oh, but we're not going to put any resources into cessation. Having said that, another thing that's, if you want to look specifically at cessation, not policies that drive cessation, Medicaid and other kinds of insurance companies are perfectly capable of providing cessation treatment. Not all states provide the same cessation benefits with Medicaid, but one thing that could really be effective is for Medicaid to actually provide cessation services, and not just for the first quit attempt, but for multiple quit attempts. Other states have waived, if there's a 5 prescription drug limit per month for a recipient, some states have waived that for nicotine replacement therapy, so that doesn't count. That drug does not account against their 5 drugs. So there are several things you can do at the policy level as well as at the cessation level. And you could also put more resources to the quit line so that there's more resources available for people who want to quit.
Okay, great, thank you. So we have time for one more question. So here is, I think this will be our last question. What is the single most important focus for oral health advocates given the current research? Should it be policy? Should it be education? What demographics? And specifically, it appears that smokeless tobacco is often left out of these campaigns or strategies. So what can we do surrounding strategies and smokeless tobacco campaigns?
I think one of the most important strategies is to try to denormalize it. And I agree with that comment. In the state of Mississippi, we started focusing mostly on cigarettes because that was the most prevalent. And a couple of years ago, Well, actually, about 4 years ago, we realized that we were driving cigar and cigarette smoking way down, and that smokeless tobacco was at the exact same prevalence it had been 15 years ago. We weren't really making any impact on it. And we've started trying to denormalize smokeless tobacco, because I think in a lot of ways we've totally denormalized cigarette smoking in most populations, but a lot of times because smokeless is not combustible, it's been seen as more acceptable. I'm really excited that a lot of major league parks are beginning to ban the use of smokeless tobacco on premise, among the baseball players and the people who are white spectators. I think the more that we can do to denormalize that behavior, the more impact that we can have on reducing the use of it. And we can denormalize it, I think, through a lot of policies, rather than having a smoke-free policy, having a tobacco-free policy and being strict with it, so that somebody, one of the things that we're running into in Mississippi is we have a law saying that you cannot smoke, so you cannot use any tobacco product on school property whatsoever. But we ask our students in our youth tobacco survey, and we say, have you seen anybody using tobacco products? And we find out that on the soccer field and the baseball field and the football field, the coaches are using smokeless tobacco. And we find that if the student tells us that their coach is using smokeless tobacco, they're more likely to be a tobacco user. So I really think stronger policies restricting the use of smokeless tobacco would go a long ways towards protecting people.
Absolutely. Great. Well, thank you again, Dr. McMillan. We appreciate your time. I want to invite everybody to look at Dr. McMillan's website, mstobaccodata.org, for more information on his strategies and campaigns in Mississippi. You can also visit ROHDEO.org, ROHDEO, to view this webinar when it's archived, and all of our other webinars. So thank you again, and we hope that you have enjoyed this presentation, and we hope that you'll join us again for the next webinar in this series. Thank you.